I was born and brought up in and around Mahatma Gandhi's ashram in Wardha district. My father was a freedom fighter, he had worked with Mahatma Gandhi. So I was born, grew up there. I studied in a school which was started by Mahatma Gandhi in Sevagram ashram itself. I think the exposure to Gandhian philosophy and villages at that time inspired me to become a doctor with a specific purpose, how to improve health and healthcare in rural areas, rural India. That was my goal. That's why I went to medical college, studied there, went to the US to study public health further. And then on returning, my wife Rani and I, we decided to select Gadchiroli for our future work.
Our purpose was to serve the most underprivileged and disadvantaged people, and that way Gadchiroli was separated from Chandrapur in 1982 and we came back in 1985. So we thought that whatever we have learnt in our medical curriculum and at Hopkins, we should make use of it in this area where there are no other health services like clinical services, other services. You won't believe, but I did the first cesarean section in this district. Nothing was being done that time, and it was a bold decision, but we were both determined and it was a voluntary choice. And when we look back, we think that it was the wisest decision we have taken in our life. And we are really honored. So many people here, they give us chance to serve them. It's a great honor for us.
Let's go back to 1988. For the first time, we measured child mortality rate in Gadchiroli in 1988 in nearly 1 lakh population, nearly 100 villages. And we found that the infant mortality rate at that time was 121, too high. And pneumonia in children and newborn deaths, these two were the main causes of death. At that time, there was no global or national program to address these two specific issues. How do you provide care to children and neonates in rural areas where Gadchiroli hardly had only few doctors and who would go and live in villages? So in search of solution, we, out of desperation and practical necessity, we thought a literate man and woman in the village is the best solution. We called them Arogya Doot, messengers of health, and we selected from each village such men and women, one per village, provided them training, skills, and this role as to if child is sick, examine, diagnose, if it is pneumonia, treat with oral antibiotic. That pneumonia treatment alone brought down infant mortality rate from 121 to 80 within 2 years. But the remaining problem was even more difficult. It was largely among the neonates. Out of 80 infants who died now, 60 died in the neonatal period, that is first 1 month. Now a newborn, not only in Gadchiroli but anywhere in rural India, is a very vulnerable, tiny, fragile human being. Its survival is difficult, and if needed, if no care is available, because there was no pediatric or neonatal hospital in the entire 300 kilometers. So I decided that probably we should train village women to become village level neonatologists. And that's how I designed this home-based newborn care in 1990, started implementing it in 1995, and Surge developed a team really for implementation. We selected 39 female community health workers to work as Arogya Doot. So the Arogya Doot, the mother, grandmother, and at that time there were dais in the villages, dai. These 4 kind of women became the main pillar who provided the newborn care at home. Because mothers and babies immediately after delivery were not even allowed to step out of that home delivery room, from that dark room. So if they couldn't come out, we must go there with the medical knowledge. So it was provided through these 4 pillars, but mainly through the trained community health worker. We provided for 3 years with good supervision, quality, etc. But then results were remarkable. Infant mortality rate is considered to be a very tough challenge. At that time, WHO recommendations were if any neonate is sick, immediately refer to hospital. So, neonates were the most difficult part of infant mortality. With this approach, newborn mortality in 39 villages where we introduced reduced by 62% within 3 years and subsequently 70%. That was remarkable. And so the Lancet immediately published this successful trial. Later on, Lancet selected this as one of the vintage papers published in 180 years of history of Lancet. We repeated it in other parts of Maharashtra with voluntary organization. The Indian Council of Medical Research replicated in 5 states. Everywhere, newborn mortality, infant mortality steeply came down. So, the Planning Commission and Government of India selected this to be expanded into the entire country. At the same time, ASHA program was developing. So, ASHAs were to some extent developed on the model of our Arogya Doot. We were asked to design a system to train 9 lakh ASHAs in India. That we did, and after 6 years of work, this became national policy and 9 lakh ASHAs were trained to provide home-based newborn care. 2 years ago, Government of India informed me that year 1 crore 10 lakh rural neonates received home-based newborn care.
The first thing what we did here was, I am a gynecologist, and in my experience I always felt that the whole maternal and child health program of Government of India was focusing on family planning. Of course, I am not against family planning, but family planning should be for the better health of women and children. And India's family planning program was population control oriented, target oriented approach. So people never felt that it was their need. And maternity care was equated only to antenatal care, giving 2 shots of tetanus toxoid and doling out iron calcium tablets. But in my experience as a gynecologist, I found that from menarche to menopause and even thereafter, women have so many gynecological problems like menstrual problems, sexual problems, they have got reproductive tract infections, what we call white discharge, they have pain in abdomen, pain in back, and they have breast problems. All these problems are there. And when I did a computerized literature search in Washington, which is supposed to be the National Library of Medicine in Washington, which is supposed to be the biggest library in the world, I found that there was not a single study to show what was the prevalence of these gynecological morbidities at the community level. And so I decided to work on that. And when I presented this thought, many people just ridiculed me and they said, what is there in gynecological problems? White discharge is an innocuous symptom like nasal discharge. But when we came to Gadchiroli, I talked to 100 key informants and I asked them to write down 1, 2, 3, 4, 5, 6, right? They could not write, but tell me what are the common problems. And number 1 problem was white discharge. And then whatever 10, 12 problems they told me, I asked them to divide it into 3 categories: mild, moderate and serious type of disease. And to my surprise, I found that 100% of the women put obstructed labor and infertility in the most serious disease category. In obstructed labor, of course, there is a chance of death and we consider it as a serious problem. But infertility, there is no death. So I asked those rural women and tribal women, why did you put these 2 together? And these women gave me such a wonderful reply. They said, Madam, if there is obstructed labor, that lady dies only once in her lifetime. But if there is infertility, she dies daily. Because everybody blames her for her infertility problem. Nobody thinks that husband is at fault. And so whatever my conviction was there, it was strengthened. And then women said that government is only interested in cutting our tubes to make us infertile, but already those who are infertile, there is no treatment available for them. So I did the first community-based study of gynecological problems in rural area in Gadchiroli. That study was published in Lancet. It's supposed to be the first study of its kind in the whole world. And I showed that 92% of the women had gynecological problems, and only 8% of the women had ever sought any care for gynecological problems. 50% of the women had reproductive tract infections. Nearly 37% of women had menstrual problems, they had sexual problems, sexually transmitted disease, and then nearly 50% of the unmarried girls had premarital sex, which was, I was not surprised because I see it daily in my OPD, but that was a big surprise for others, and it was in rural area, not in tribal area. And then it was published in Lancet, and it drew a lot of attention from different international agencies, women's groups. I was called to WHO for World Health Assembly, and I presented this study there. And in 1996 again there was a Cairo conference, and the total policy in the world changed. Previously they used to call it maternal and child health, and I coined the word reproductive health and child health. So that word was coined by me. WHO started special division, ICMR, Indian Council of Medical Research, started special division, and the policy all over the world changed because of this first gynec study. And then I trained the traditional birth attendants to treat the gynecological problems at the community level, because there were no gynecologists and there was no transport, no communication, and we couldn't expect women to come to gynecologist. I was the only one.
104 million tribal people live in India, and more than half of them live in remote areas, forests, jungles, hills in the northeast. Now, Government of India had appointed an expert committee, national expert committee under my chairmanship. After 5 years of work, we produced a report. It's the first report after independence, Tribal Health in India. So we found that the health status of tribal people was worst as compared to any other social section in India, and major disease killers and major gaps were identified. There was huge funding budget, government funding deficit to tribal health. Human resource was not available. So we have made several solutions, we have recommended several solutions to bridge this gap, so that to bring the health status of tribal people anywhere in India at par with the non-tribal population of the same state within 10 years. We have recommended by 2027. We recommended it in 2018, now it is 2022. We wish that the goal should be achieved by 2027 if Government of India and state governments act on it. We came to live in this tribal block of Hanora in 1992. So how to provide care? So we thought of naturally hospital. We collected tribal people from 50 villages and we asked them, what sort of hospital would you like to have? Why don't you go to government hospitals? They said, we are afraid. We are afraid of big buildings. We are afraid of white coats. We are afraid of the language that they speak there. They laugh at us. So we realized that if we want tribal people to seek care, not feel shy, not feel afraid, we need to build a tribal friendly hospital. So taking inspiration from Mahatma Gandhi's Sevagram Ashram, we constructed here our first tribal friendly hospital of huts, which looked like a tribal village, didn't look like a hospital. And to again make tribal people feel safe and secure, we created a temple of their goddess. Their goddess is Danteshwari, and that's why this hospital was labeled by tribal people as Ma Danteshwari Davakhana. It had a unique design. Its origin and generation itself was through consultation with the tribal people. So it became a sort of a collaborative partnership between tribal people and us.
If there is no proper maternity care, she may die, and if she is malnourished, then it influences the child's growth. So undernourished children are born. Then secondly, there are stillbirths, there are neonatal mortality in children, childhood mortalities because of infection. So we have to definitely focus on maternity care. both antepartum, intrapartum and postpartum care also, because postpartum infections, postpartum bleeding, postpartum mental disorders are very common in rural area and urban area. Nobody thinks about it. So we have to focus both on the mortality aspect and the morbidity. Unless the quality of life is good for rural women, because they have to bear the triple burden of earning for the family, then doing all the household work, and then producing children and taking care of the children. So their quality of life should be good. So I thought that not only maternity care, but we should focus on other aspects of reproductive health.
We have to first accept that genetically tribal people and non-tribal people are almost same. So they are not genetically inferior in any way. They have been left behind in the development of science and other development. But if you look at several other aspects, tribal people are far ahead of us, and actually we should be imitating them. They live with the nature and forest in harmony. They don't destroy it. So in the current era of climate change, that is the first thing we should learn from them. They live in a communitarian way where a lot of things are shared together, as compared to our lonely, alienated life in urban areas where everybody is competitive and stressful. This is far more productive and happy life. Tribal women, in some sense, they are freer than the average middle class woman in India. A tribal girl is allowed to marry with a boy or man she wants to marry. She has that freedom. In tribal societies, you practically never hear about rape committed by a tribal man on woman. If at all rapes are committed, they are by non-tribal coming from outside. So tribal women have, in some sense, she can divorce husband if she wants. So tribal women have a lot of more freedom than we have. And lastly, constitutional amendment of PESA, as it is called, has given tribal Gram Sabhas rights for grassroots democracy. This is almost revolutionary. If it is really implemented in practice, tribal Gram Sabhas and tribal grassroots democracy would be far better than in the rest of the places. So on this World Health Day, I would like to appeal that these 11 crore tribal people in India should not be left behind, and we should learn from their good social customs, practices and qualities.